Good evening, everyone, and welcome to this showcase on public health and from the School of Public Health. And thank you for attending this event to really explore the role of public health in pandemics. We're all obviously now collectively experiencing one of the first pandemics in this century that's impacted us quite significantly. We have a great program today for you with a presentation, a short seminar by Associate Professor Linda Selvey from our school. I'll just, whilst I'm speaking, wait a few more minutes for the extra attendees to arrive. But what we hope you'll enjoy is a presentation by Associate Professor Selvey, followed by an opportunity for you to ask any questions that you have for a panel of my colleagues and myself. Before we begin, I just want to acknowledge the traditional owners of the land that we collectively meet, the Yagara and Turrbal people, and pay our respects to their ancestors and descendants who continue cultural and spiritual connections to country. We recognise their valuable contributions to Australian and global society. And for those who haven't seen the University of Queensland artwork, we were very privileged to have a wonderful artist work with the university to develop the reconciliation artwork, and this artwork represents the St Lucia campus. So this is a list of the panel members that we'll have tonight, and as I suggested, the Associate Professor Linda Selvey will be speaking to you on pandemics and public health responses. I'm the Chair of Teaching and Learning, so I have a broader remit within the school. We have our Director of the Masters of Public Health, Shelley Lawler, the Masters of Epidemiology, Professor Lisa Hall, the Masters of Biostatistics, and Michael Waller, and the Masters of Environmental Health Sciences, which is a new program the school began for the first time last year, and that's Associate Professor Coral Gardner. So I'll just begin the presentation. Sorry, you'll just have to. So we'll begin with a short seminar by Linda.
Well, today I'm going to talk about the role of public health in pandemics. And before I move on, I'd just like to start by acknowledging the traditional owners of the land where I'm doing this, the Yagara and Turrbal peoples, and pay respects to their elders past, present and emerging, and any Aboriginal or Torres Strait Islander people who may be watching this video. I'm going to talk, this is the outline of what I'm going to talk about. I just wanted to, while we're in the midst of a pandemic now, I will talk about COVID-19, but I'll also talk more broadly in relation to pandemics. And so I'm going to start by giving a bit of a history of pandemics and then talk about the different public health disciplines and how they apply to pandemics. So this slide is a really nice visualisation of a whole range of different pandemics that have occurred over the years. And the size of the bubble in the diagram is an indicator of how many people have died from the pandemics. And it doesn't show all pandemics, and in fact some of the ones in the most recently, for example SARS, Ebola and MERS, weren't actually considered to be pandemics, because while they did affect more than one country, they weren't considered to have worldwide spread. whereas the others were more widespread. One of the things you can see from this is that there were some pandemics that resulted in very large numbers of deaths. For example, the Spanish flu, which interestingly didn't actually emerge in Spain. It's thought to have emerged in China like most influenza does. But it caused a very large number of deaths. And we sometimes forget about HIV, which is another pandemic that the infection's still with us. There's still no effective vaccine, and that has caused a very large number of deaths as well. One of the things you can also see from this is that it appears that there have been more pandemics recently compared to many years ago. Some of that may be due to our increased ability to detect pandemics, but this is also likely to be real because people now, with our capacity for international travel, much more urbanised populations and so on, we've got many more opportunities for mixing of people and therefore spread of infectious diseases. So I thought I'd start with a bit of a definition of public health. Sometimes we can think of public health as maybe being related to public hospitals, but in fact public health is the science of protecting and improving the health of people and communities. And we do this through promoting healthier lifestyles. We also research disease and injury prevention, and we detect, prevent and respond to infectious diseases. And public health has really become in the forefront in recent times due to the COVID-19 pandemic. I've listed here the range of disciplines in public health. As you can see, they're many and varied, and they're all areas of expertise within themselves. And what I'm going to do now is talk about them in the context of a pandemic. Clearly, when we think about a pandemic, communicable disease surveillance and control is the first thing that springs to mind. And you would have heard from many public health experts who are experts in the communicable diseases space in recent times. So most of what the next part I'm going to do is going to talk about communicable diseases surveillance and control. But I thought I'd start by thinking about what happens before a pandemic emerges, because in recent years we've been in the anticipation of a pandemic. There's been a lot of work in terms of planning and preparation for a pandemic. And the reason why this happened was because in recent years, since the Spanish flu pandemic, there have been influenza pandemics happening periodically over time. And it was felt in the mid-2000s that it was likely that there would be another influenza pandemic emerging, and so therefore there was an enormous amount of work put in terms of planning and preparation. And with the planning needs to happen at a range of different levels. It needs to happen at the public health perspective, but also planning and preparation of health services, as well as across all government agencies and non-government sectors. Because as you're seeing now with COVID-19, the pandemic is affecting everything that we do. Well, once the plans are in place, then it's important also to exercise and review the plans to make sure that they're up to date and that people know what to do in those scenarios. But there's also a big investment in capacity building, both in terms of laboratory capacity, and that's happened around the world, also in low and middle income countries, supported by the World Health Organization and the US CDC, clinical capacity building as well as consumables. And Australia, as many countries do, have a national medical stockpile, including of PPE, as well as laboratory capacity and drugs and so on. So all of that is important before a pandemic occurs, but public health is integral to that. It's led all of that planning and preparation. While it involves a very range of people, public health is the leader. So, for example, I led the whole of government pandemic planning when I worked for Queensland Health. So then what happens when a new disease of pandemic potential emerges? Well, a disease will emerge in one place, and so what I'm going to talk about now is what happens in the country of the disease origin. And the first thing you can see there is identifying clusters of severe and unexplained infections. Now that might sound like a simple thing, but many times the symptoms that are associated with those particular infections may not be all that specific. For example, with COVID-19, having a severe respiratory pneumonia may not be that different to other causes of severe pneumonia. And doing this actually requires people to be on the alert, clinicians who are likely to see these cases coming into hospital, potentially workplaces that might see changes or increased illness in their workplace and in the community. Once that alert is there, then public health can move into the act in terms of that initial investigation. And a key thing that we do early is to try and find more cases, to try and get a bit of a sense of how widespread this is, because we may be, the alert may have happened due to a small number of cases. So just to really get a sense of what's going on. So that requires quite a bit of detective work and public health people to be in touch with clinicians and other and the community. As well as that, it's important to identify the pathogen. What's actually causing this cluster or these severe infections? And here laboratories play a really important role. And that may not be an easy thing. It can sometimes be very difficult to identify the agent because it's new that's actually causing these infections, because there isn't necessarily a laboratory test available. So laboratories also then, once they've identified the pathogen, develop a laboratory test. And once that test is available, it makes it much easier to then search for more cases and to undergo more investigation. Public health then, through these cases, is public health practitioners are doing the detective work of trying to understand the commonalities. How might this have been transmitted between people, and what are the risk factors, to help really understand the situation and to put in place prevention. We also then, in collaboration with laboratories and clinicians and the community, initiate surveillance. When we talk about surveillance, what we're trying to do is to identify the cases so that then there can be a public health response. We need the laboratories and clinicians to help us do that, but public health people are the people that put those things all together to investigate the cases, to provide more information and keep track of things, just like you're hearing about the different case numbers of COVID-19 at the moment. And an important part, once it appears that this may spread worldwide, is to inform the World Health Organization. And we now have international health regulations that are in place, that came in place, agreed to by all member countries post the SARS outbreak, where there's a requirement for countries to notify the World Health Organization and through them other countries that if there's an infection that may have pandemic potential, may be likely to be able to spread further. So once other countries are informed of it, then it's really important then for those countries to be ready. And the first thing that needs to happen is to monitor what's happening in the country of origin. So that involves really getting that information from those countries, from where it is, in order to keep track of things and determine the likelihood that it will come. And the preparation then builds on what had been done prior in the planning phase, but really making sure that do we have the laboratory test capacity? Do we have the clinical capacity to deal with the nature of the infection that's emerging in the country of origin? Do we have the public health capacity, the surveillance, and think about things like border measures? And again, public health is the leader. We can't do that alone, but we lead it and work with these other agencies, particularly clinicians, laboratories, and of course government. And then we need to also communicate. We need to communicate directly with decision makers, but also with the public about what's happening, so that people can also prepare and also make their own risk judgments in terms of travel and so on. And then it's because it's a pandemic, eventually it will be here. So what happens then? Well, the reason why I've showed these different pictures on this slide is because what we do depends on the nature of the pathogen. So with HIV tends to be spread by blood-to-blood contact and sexual contact. And that virus wasn't something that was prepared for. By the time we became aware of it, it had already spread from many places from its country of origin. And in responding to a pandemic such as HIV, where the main transmission is blood-borne and sexual transmission, required an entirely different set of responses. With HIV, because particularly in Western countries, the main mode of transmission was through men having sex with other men and anal sex, a lot of work had to happen in terms of social measures, supporting and also removing a lot of the stigma and discrimination and legislative impairments, both to that and injecting drug use. That has all been part of a response to HIV in Australia and around the world. I've got a picture here of to identify that some people consider the increasing rates of obesity around the world to be a pandemic, and it has many hallmarks of a pandemic, even though it's not an infectious disease, because of the fact that the drivers of obesity are spreading around the world. And obviously the response to that is going to be quite different to the response of an infectious disease. During the pandemic that occurred, infectious pandemic that occurred most recently prior to the current one, the swine flu H1N1 2009 pandemic, there you might have noticed in response to COVID-19 that contact tracing is an important component of the response. With influenza, because it has a very short incubation period, you can be exposed to it and develop symptoms even within that day. There's no time for contact tracing. But with influenza, fortunately, because there are many other influenza strains that we have vaccines against, vaccination was an important response. With COVID-19, you would have seen many parts of that response, but it's important to think about the communicable diseases side of the response, but also think about all the other ways that public health is contributing to this pandemic, and I'll talk more about that in a minute. So I'm now going to talk about the public health disciplines, and you can see again some of the other disciplines, and I've highlighted there epidemiology and biostatistics. So all that the surveillance, all that information that comes from surveillance, the data need to be interrogated and understood, and the disciplines of epidemiology and biostatistics are critical for that. So in terms of the response to COVID-19, many epidemiologists working in a range of different areas are now helping health departments around the world with helping them to manage their data and to analyse their data in order to understand what's happening locally as well as further afield. Disease modelling. You may have been, in recent times, might have been the first time you've ever heard of disease modelling, but disease modelling is a growing discipline within public health. It tends to be people who do that work are applied mathematicians, but they work very closely with public health people. It's really important in terms of both planning and preparing for potential pandemics and other infectious diseases, but it's also being used more and more in chronic disease space as well. I think this diagram really talks about how disease modelling kind of informs what we do. You start with the policy question, and it has to come from some initial data that needs to be available so that the modellers have something to work with, and then that helps to increase our understanding. Remembering that the modelling is only as good as the data and the assumptions that you put into it have. And then through developing that scientific understanding, we start to get insights that then point to what additional data we need to collect that then can inform policy advice. And much of the advice in relation to the response to COVID-19 has come from information arising from this disease modelling. And then disease modellers are increasingly wanting more and more information to help them to do better modelling. Environmental health is an important public health discipline in terms of infectious diseases more broadly, but also in terms of pandemics. And I've highlighted two pandemics at the top there for which environmental health was critical in terms of responding. With plague, as you could see from that first slide, there were many pandemics of plague over time and killed millions and millions of people. And that plague was transmitted by fleas that bit rats and then bit people. And while plague is much less common now in the world, it still occurs in some parts of the world. Cholera is a waterborne disease, and access to clean water, which is an important environmental health measure, is a way of preventing the spread of cholera. And of that last slide, I've got questions about COVID-19, but for many respiratory illnesses, we know that air pollution, because it irritates and inflames our airways, may make people more susceptible to more severe respiratory infections. I've highlighted health promotion and risk communication there, and I've given the example with HIV. Health promotion practitioners were critical in terms of responding to that pandemic. But even in more acute pandemics such as the one we are, health promotion people are really important in terms of making sure that we have what's in place in order to help people protect themselves from COVID-19 and other infections, but also to help in terms of providing that messaging. And that's where risk communication really comes into the fore. And health policy is another important area, and you would see a rapid development of policy and legislation in recent times in terms of response to COVID-19. But health policy in general is a key instrument of public health in terms of protecting the health of populations. So I'm now just going to talk briefly about our School of Public Health. I'm very proud to be working in the School of Public Health at the University of Queensland. We're ranked equal first in Australia and 23rd globally for public health. And when you think about the very large numbers of schools of public health around the world, that's quite an achievement. We offer a number of courses in programs in public health. First of all, the Master of Public Health. I do hope some of you come and join us here. It's a 1.5 year program, and Dr. Shirley Lawler is the director of the Master of Public Health program. Our Master of Environmental Health Sciences is a new program. It's a 2-year program, and it's one of the features of that is that it involves every faculty at the University of Queensland. It's responding to some of the emerging challenges in terms of environmental health around the world, and is a really exciting program. And Associate Professor Coral Gartner is the director of that program. The Master of Biostatistics is a 2-year program. It's delivered by the University of Queensland together with other universities around Australia, and Dr. Michael Waller is the program director. And the Master of Epidemiology, you saw how important epidemiology and biostatistics are at the moment, is a 1.5 year program led by Associate Professor Lisa Hall. So thanks very much, and we look forward to hearing from you with your questions.
Okay, thank you very much, Linda. I'm just going to, we now just move to the Q&A part of the the evening. And so now I would ask all our panelists if they could just turn their cameras on so that we can see everyone. And we have some questions here that we'll, sorry, I've just made a mistake on one of them, sorry. We have some questions here that we will start with the proceedings. So the first question that was asked was whether the role of public health is become more important, or whether it's always been important but hidden. So we'll I'll just ask Linda Selvey if she could answer that question.
Sure. You know, public health has always been critically important in responding to pandemics. I think it's mainly that previously it had been more behind the scenes, but because of the very large attention to COVID-19 globally, because of its huge impacts on our society, public health has become a lot more prominent. But public health, for example, were critical in responding to the H1N1 2009 pandemic. Public health continues to be critical in responding to the HIV pandemic and many others previously.
Okay, thank you, Linda. And I guess in some ways, public health sits running in the background, a bit like, you know, the sort of I guess people's awareness of things like cybersecurity. So public health is always turned on, switched on, and it runs and monitors the health of the populations on an ongoing basis. So I guess there's a constant demand for people with the necessary skills to work in public health. So the next question is a good one with what makes a disease a pandemic. So again, we'll ask Linda if she can answer that question.
Yeah, sure, Simon. So a disease becomes a pandemic when it's able to spread around the world. And what is required for that is that initially it's very difficult to contain in the country of origin. And then there needs to be some mechanism of spread where it can move from one country to the next. So, for example, SARS did move from its country of origin, China, to a number of other countries, including Canada and South Korea. But it didn't spread worldwide because it was able to be contained within those countries once a containment strategy was developed. So it didn't spread further. Whereas COVID-19, while there were major efforts to contain the virus, it wasn't able to be contained sufficiently quickly in its country of origin before it spread, and then it was unable to be contained in those other countries. So I guess the main characteristics are then that infections that become pandemics are much more difficult to contain, and then there needs to be a mechanism for that spread. And because people now travel and move around much more quickly, and a lot more of us move around, that means that there's much greater ability to spread infections that are transferred from person to person. For example, with plague, which became a pandemic, as I mentioned in my talk many times, that was actually transmitted through, spread worldwide through rats, and ships took infected rats, and then the rats emerged and spread in different countries that way. But most recent pandemics have spread from person to person.
Great, thank you, Linda. So the next question is one about smoking and the severity, so the clinical severity of the disease. And I think Linda's put her hand up to answer that one as well.
As did Coral, so I'm happy to pass that one to Coral.
Okay, Coral, go for it.
Okay, so this is something that's been studied with the COVID-19 pandemic, and there's been a number of studies now done in a few different countries, and it's they're using data from patients that have been admitted to hospital. So they are relying on some data that's not the best quality, because if you can imagine, when people are coming in sick, they don't always get all the data that you would like to collect from sick patients. But what we have seen so far is that people who smoke are at greater risk of more severe symptoms if they've been hospitalised with COVID-19, and they are at greater risk of going into intensive care units, being put on a respirator, and also higher mortality rates there. So there has been a little bit of controversy about whether some people have claimed that smoking may be protective against COVID-19. The evidence on that is pretty slim. So that's based on, there have been fairly low rates apparent of people being admitted to hospital with COVID-19 if they smoke, compared to the rates of smoking in the population. But this may just be an artifact of poor data collection, or it could also be that there are a number of other explanations that may explain this. It may be that people are too sick, if they're smokers, when they come into hospital, that they're less likely to be reporting all their risk factors because they're just too ill if they develop severe symptoms more quickly than non-smokers. So it's like a type of bias that may be happening there. But this, I guess, phenomenon has been seen in a number of countries now, and I have done meta-analyses. So what we see consistently is that while there seems to be fewer smokers being reported as having COVID-19, they are at much higher risk of greater disease when they are recorded as having COVID-19. So our recommendation is strongly to quit smoking, and we're not convinced that it is a true protective effect. And if it is, there are lots of reasons why you would not smoke as a sort of preventative of COVID.
Great. Thank you, Coral. Michael, the next one's over to you, the difference between biostatistics and epidemiology.
Yeah, well, the biostatisticians and epidemiologists will often be working closely together, but I would say that a biostatistician is more likely to be focused on the application of the statistical methods to answer the research question in hand. So they'd be more likely to be involved in the analysis of the data, whereas a epidemiologist's role is likely to be broader. Lisa?
Yeah, I'm happy to add a little bit extra to that. I suppose epidemiologists move a little bit more broadly than just looking at the data. We interpret it, but we also look at the effectiveness of interventions for prevention and control. We're kind of the study design experts in this whole equation, and we work very closely with health promotion, environmental health, disease control and surveillance at looking at what data needs to be collected, and then working with the statisticians around how that's going to be analysed. So you will have seen a lot of epidemiologists also. There are some epidemiologists who specialise in disease modelling as well, and they're some of the people that you've seen in the press more recently.
Great. Thank you, Lisa. So the next question centres around the, I guess it's the politics now of pandemics and the issue around the blame game that's emerging with countries pointing the finger at China. Perhaps we could ask Linda to make a comment on that.
Sure, Simon. I think, well, as you know, the COVID-19 emerged in China, and the criticism that the US had about China in particular was about a criticism, an allegation that they were slow to contain the virus, and that they also may not have informed the World Health Organization about the epidemic as quickly as they might have. So some of that is political, as you know, and I might not go into that in a lot of detail, but you might be aware of other situations when the current President of the United States has been publicly critiquing China. I would like to say that when we look at what China did in terms of containing the virus in their own country, they were incredibly successful. as I said earlier, it's actually very difficult to identify new clusters of disease. China is well prepared for that because they have had outbreaks of avian influenza previously that they also managed to contain. So I think through their high level of alertness, they were able to recognise this epidemic much quicker in China than would have been likely to have been able to achieve in many other countries. And I think the question of how quickly they informed the World Health Organization is probably not one that I would like to comment on. But I think generally countries do need to establish that they have this new infection and what it is before they would inform other countries. Australia hasn't been so critical of China as much as calling for an inquiry or an investigation into the pandemic that I understand China has now agreed to through the World Health Assembly. And that would make sense given the implications of the pandemic, but probably needs to be timed in a way that it doesn't interfere with the response.
Great, thank you, Linda. So there's a question that I accidentally clicked on the wrong button and it's gone to answered, so I'll answer that as well, is how do diseases spread from animals to humans? And I'm happy to answer that question given this is my particular area of interest. So zoonotic diseases, so diseases that spread from animals to humans, are actually quite common. About almost 60% of the diseases of humans now and I guess through history have come from animals originally. So there's no, I guess, one easy answer in terms of how. I mean, the how they spread is through contact. So people come into contact with animals directly or indirectly. So it may be through eating parts of the animal, involved in, people who are involved in animal husbandry, so raising animals. And it really depends entirely on the different organisms. If we look at COVID, the animal host is not really understood fully yet. There's good suggestions that it's originally from, or the original host is from a bat, and that's really based on history and SARS and the first coronavirus, SARS coronavirus outbreaks. So the evidence there was the jump was made from bats into civet cats, and civet cats are a small vegetarian cat that people consumed, through eating wild animals. So the link was really through contact between bats and civet cats and humans through the food chain. So they're really quite complex processes, and what it really points to, I guess, is that we are increasingly seeing these emergences and also seeing increases in foodborne illness. So I guess it's a challenge to know that once you know how they spread, to then work out how to prevent it, because it's not a simple task of banning wildlife. So China has now, particularly in Wuhan, they've now banned wildlife consumption and trade. But as we know from every other human desire, it's likely to make that an underground event now. So it's an incredibly complex task to manage these things. There is also a couple of messages being put onto the chat, which we will come to. So those people who've put those questions up, don't worry. I'm just scrolling down, sorry. So there's a question here about courses in epidemiology that I'll pass on to Lisa.
Right. So the interesting thing about all of our programs in public health is that you can start at a very base level, and you can actually enroll in most of our subjects as a standalone non-award course. So if you have the right prereqs and background, if you've done any of the sciences or any of the health disciplines, you can just enroll in one subject, one course, say intro to epidemiology or intro to stats or intro to public health, and just do that subject. that you can then use it as credit towards a grad cert, a grad dip, and a master's. And every year we have people who start with a non-award, who then transfer into a grad cert of epi, for example, and then decide that they really love it and continue on to do a master's. But you certainly do not have to commit to doing a master's of public health or a master's of epi straight up front. You can actually see how you go and whether you like the discipline first.
Okay, thank you, Lisa.
Shelley might have something else to add.
No, I think you covered that off nicely, Lisa. You can do that for any of our courses. You can take them as a non-award, and then if you like that particular area, you can choose if you want to do a grad certificate or a graduate diploma. And then you can even articulate there up to a Masters of Public Health once you've got a taste to see if that's something you like doing.
Okay, thank you, Shelley and Lisa. So the next questions is one about community equity and whether the pandemic is simply a clinical issue. I just wouldn't mind asking Shelley to make a first response to that, and if there's still some information Linda would like to pass on, then she can follow on, please.
Okay, thanks, Simon. I think that when we see what's happening, we see the forefront of what's happening in our response to the pandemic, where we see all our clinical frontline workers. And with public health, we are part of that. We're part of that system. And of course, when we're thinking about our response to pandemics, we are thinking about the collective. So of course, we have to think about the community so that the response is equitable across everyone, so we have a collective impact. So absolutely need to think about those other interactions, because public health is looking at those complex interactions of all those determinants of health. And we know that there's a number of those that are at play, even with our responses to pandemic. Linda, did you have anything else you wanted to add?
Just to say that that's where that whole of government response also really becomes important. So we can't address a pandemic, particularly in an equitable way, without engaging other agencies within government, but also non-government organisations as well.
Okay, thank you. So there's the next question on the Q&A is before COVID. So we'll now have a before and after COVID date that everybody will remember. And I'm sure when everybody on this chat is old and they'll tell their grandchildren what they were doing the day the pandemic was declared. So this one is about what were the main priorities in Australia, and Linda would like to start the answer for that one.
Yes, well, from an infectious diseases perspective, probably one of our biggest priorities would have been influenza, simply because influenza is responsible for a very large number of deaths around, in Australia every year. While there is a vaccine against influenza, it's not as effective as we would like it to be in the most vulnerable populations, that is the elderly. And influenza spreads very rapidly in the community, and every year we get a new strain, or sometimes more than one strain. Other infectious diseases would be of priority would be other vaccine preventable diseases, because if we don't continue the vaccination rates, maintain them at a high rate, those diseases can come back and have in previous years been responsible for many deaths and morbidity and mortality. And then I'd also probably mention that HIV and hepatitis C continue to be problems. They're chronic infectious diseases, so when people are infected or with HIV is infected for life. Now with hepatitis C there's an effective treatment. And many foodborne infections are also important. So there's plenty in the infectious diseases space to be concerned about. In the non-communicable diseases space, that in Australia and across the world until COVID-19, that will remain critically important non-communicable diseases such as diabetes, heart disease, and or cardiovascular disease, as well as cancers, and they're becoming increasingly important throughout the world as people's general health is reduced due to growing rates of obesity and reduced physical activity and poorer diets. And that continues to be a problem and will continue to be a problem into the future.
Thank you, Linda. Shelley, would you like to add anything to that?
No, I think Linda's covered that off well. I think you're right. I mean, we're facing the pandemic at the moment, but those non-communicable diseases don't stop. So there still is a lot of public health work that is happening in that space in terms of that health promotion as well, and that risk communication, so that we can improve people's physical activity, reduce their sedentary behaviour, and improve nutrition. And those are all things that we cover in the Masters of Public Health.
Great, thank you. So the next question is quite a complex one. So and it's really looking at the coordination. How challenging does the complex Australian health system make responses in terms of states and jurisdictions? I will hand over again to Linda, because she is the most experienced person in the room when it comes to the governmental response.
Yes, thanks, Simon. There are a number of mechanisms that are have been used now for many, many years to get this coordination between jurisdictions and the Commonwealth, because our decentralised health system has caused challenges in the past in relation to infectious diseases, but over many years there's been a lot of work to limit those challenges. So the mechanisms include the Communicable Diseases Network of Australia, for which there's representatives from each jurisdiction, as well as some expert representatives whose role is to coordinate the surveillance and response to communicable diseases. And I'm sure you will have heard of the Australian Health Protection Principal Committee, the AHPPC, which the Communicable Diseases Network reports up to. There is also the Commonwealth, in the Office of Health Protection, coordinates and has disease surveillance across the whole country that each jurisdiction reports to, and supports a lot of this coordinating mechanisms. Our health system is complex though, and there have been many people who argue that we should have a CDC, such as there is in the United States and in China and across Europe. I know a bit about the US CDC, which has been severely affected by reductions in funding in recent years. But their challenges are similar to ours in Australia, even though we don't have a CDC, which is that the federal agency, which is the CDC, can't actually require that cooperation between the states. It does actually rely on this more voluntary interaction through these mechanisms. So any country that is divided into jurisdictions or any entities such as the European Union do face very similar challenges.
Thank you. So the next question, I guess, is actually continuing to some extent on that, and that is a question around what the role of public health is in the current advice that the Chief Health Officer is receiving, and whether we have more certain parts of public health are more influential than others. I'm not sure who to direct.
Yeah, I can answer that again. So, yeah, Jeanette and every other jurisdiction are taking advice from communicable diseases experts in their communicable diseases control branches or directorates, whatever they're called in each country, each state. And those communicable diseases branches are generally led by a public health physician with expertise in infectious diseases and a whole range of different people with different skills that support support the director that then informs Jeanette Young. So I guess it's fair to say that communicable diseases, surveillance and control areas of public health are probably the strongest, but also epidemiology and biostatistics all work together. But generally people working in communicable diseases control also recognise and understand the importance of health promotion, risk communication, of environmental health and the other public health disciplines. So they work together with people with those expertise to provide the advice.
Thank you, Linda. And I think it's interesting talking to colleagues in Queensland Health in different parts. So even in the public health units that sit in the decentralised structure, everybody's involved, particularly early on. Even those people not directly involved in communicable disease control will also be drawn into the response. So I guess Linda keeps talking about whole of government, and this probably also trickles down to being almost a whole of Queensland Health response, just based on the sheer workload. So we do tend to focus a bit on the clinical aspects, and so we have the examination of the workloads of a lot of the frontline primary healthcare providers. And I guess the unsung heroes from our point of view are the public health units and the public health workforce, which often is now working, very long days, or 7 days a week. Certainly in the beginning of the response.
They're still doing that, Simon, I can tell you.
Oh, people have said they can take a holiday on the weekend now. So, and I guess as a point of, just to continue that point, the public health response continues after the clinical response has begun to be resolved. So we now know that there are very few cases, but that doesn't mean that the public health machinery isn't still working overtime, because it's the public health workforce that gives you the confidence. That's the data that provides you confidence to know that you don't have cases. So we will probably see a permanent change in the way that surveillance is done certainly for coronavirus. It will become part of the landscape of public health in the future. So it's certainly, from a public health point of view, this is not going to go away, and it will have knock-on effects with greater rounds of more intense planning for future events. There's a question here that I think I'm happy to answer, and that's from Martin about whether we are interested in setting up a centre of excellence. Now, we, I think, as a school and university, I guess, have very deep and very extensive experience across a wide range of areas. And to some extent, a lot of people probably didn't realise that they had an interest in pandemics until we had a pandemic. It's certainly something that the university probably will consider. It's a question of what sort of structures are used and how that is established. My guess would be that every university of decent size will probably be looking at how they can also respond to the pandemic with a research or a training centre. So the next question, again, I'm not sure who to direct this to, possibly Shelley, is whether there's any information about people with disabilities who have experienced COVID-19.
Simon, I am not across any specific evidence on that. However, we do know that obviously research groups that have interest in particular population groups, particular vulnerable populations, are very much working in response to this. And we will see evidence start to come out in terms of people with disability, Indigenous populations, people with mental health. That research will be happening, that evidence will be being collated right now, but I don't have any specific details at hand.
Okay. Thank you, Shelley. Go, Lisa.
The other thing to really add to that, it's not just about collecting data from studies, it's about our colleagues who have a sociology focus about the lived experience of people in this pandemic. And I know there's a lot of work ongoing in that space with the disability sector at the moment.
Great, thank you. So just to switch to the Zoom chat to make sure we don't lose the few questions that were asked there. So Linda, I think this one's also for you. There's a question here about border closures within Australia and globally. So in the initial phase, the WHO advised against, or at least made comments about the lack of evidence to support border closures. They were universally adopted, and we now have border closures within Australia. We don't do it for influenza. Why should we do it for COVID?
Yeah, so the WHO advice was based on the experience of the H1N1 2009 pandemic as well as SARS. So in the example of the H1N1 2009 pandemic, it had actually already spread before any border measures were put in place in many countries, including in Australia. So while we didn't close our borders, we did do border screening, which tends to not be a very effective mechanism of limiting spread into countries. But by the time that was set up, we already had H1N1 2009 in Australia. And in the situation of SARS, many countries closed their borders in response to SARS, which had an enormous economic impact. And I think that the WHO advice developed from that time because the economic impact was so great, while SARS was able to be controlled quite effectively through case identification and isolation and contact tracing. I think the situation with COVID-19 is quite new in terms of it being difficult to control. And as happened in Australia, when before we closed our borders, most of our cases or chains of transmission were able to be traced to imported cases from other countries, and so the border closures made more sense. But it actually made more sense in Australia than it did and New Zealand than it did in many parts of the world. Because in countries where there's much more porous borders, or countries that it's much easier to travel between countries, for example, across Europe, across many parts of Asia, border closures don't actually make any sense because usually they're unable to contain the situation, and also the virus can spread much more quickly between countries. So Australia has benefited very much from our geographical isolation in the terms of the COVID-19 pandemic. And I think that's one of the reasons why we've been so successful in limiting numbers of cases, has simply been our geography combined with a good public health response and border closures.
Great, thank you, Linda. So the next question on the chat is that given the current situation the world is facing, what are the ways we can strengthen public health awareness to prevent future pandemics? So this is an interesting one because the sort of global community, particularly people interested in zoonotic diseases and disease emergence, I mean, I guess the warning signs were there. The 2003 SARS emergence and outbreaks was considered to be an example of what may happen, and so there has been a lot of I guess a lot written and a lot advocated from the scientific community about pandemics. The challenge is that these are rare events and hard to define. So for example, based on the first SARS outbreaks, you couldn't really have predicted that the second SARS coronavirus would look like the pandemic we have now. So every pandemic is different, so you can't confidently say what will happen. I think what we're experiencing now is not necessarily the worst case scenario. I mean, I guess things could have been worse, but it's very, very difficult to maintain awareness of something that's rare and difficult to define. So the politics of pandemics are challenging in a world that has multiple complex priorities in other areas. And in some ways, it's much the same as some of the other health and societal problems that we're trying to tackle. I don't know if anybody else wants to comment on that. You don't have to. No. So there's just one more question on the chat, which I'll direct to Shelley. And this is an interesting one about the language that we use to communicate during this pandemic. It's been quite inflammatory at times, and as Marianne mentions, we're describing it as a war against the viruses, and she's wondering, you know, what the mental health issues are around using such inflammatory language.
That's a great question, and I think one we will see unpacked in the coming years. You know, we've seen communication across the globe from many different leaders in terms of how they've tried to rally the collective across their countries in terms of the response to the pandemic. They're all driven by different political beliefs, and their values are different, and often they'll be using the language that they think is probably going to get the best response, but it might also get them re-elected as well. So you have to remember that, you know, there is politics at play when we look at health, always. It's an interesting question, and it's one I actually have a PhD student who's going to be looking at. So she is actually going to be, she's currently looking across 3 countries at the moment. We're doing a survey to actually understand the role of leadership, particularly in government, and sources of information, trust within that kind of political space as well from the general population. And then we're also going to be measuring a number of mental health outcomes, along with the behaviours that are important in terms of restricting the pandemic. So give us a few months and I'll actually have a lot more information that I could answer that question in a lot more detail. But language and messaging is very important when we think about anything in terms of public health. Messaging needs to be simple. We need to understand that not everyone has the same literacy levels when we're working across a population. So you need to think about that message and how it's going to be able to reach the greatest number of people.
Great. Thanks, Shelley. So the next question is about large events, and we're all restricted in what we can do, and the music, what do they call, festivals and gyms. Linda, do you think we're going to see changes in these events in the future?
Yes, well, certainly until I guess, and if we end up with an effective vaccine against COVID-19, the problem with the events is not just in terms of what can be done to manage, such as through social distancing and so on. The big problem with large events is that they bring people together from a wide range of areas. So if there is some transmission of COVID-19, for example, in one small geographical area, when there's a large event, this brings together greater risk of transmission that then people can bring to wherever they came from. So that's why some of the rationale between limiting the numbers of people in different places, not just in terms of how they're spaced, is currently in place. So I think that large events will have to change, and I guess it's uncertain whether or not we'll be able to have very, very large events again until we have adequate social distancing, or at least more effective treatment and a vaccine. Although it's very difficult with something this new to be able to say that for sure.
Thank you, Linda. So there's a couple of questions about careers in public health, and so I'll hand over to Shelley to talk about career options after public health. So there's 2 questions. One is also then about the opportunity for a career in clinical medicine and public health, and whether that's a common occurrence.
Okay, thanks, Simon. There are a huge array of career options that are available to you after you complete a Masters of Public Health. And we've recently just conducted, just through LinkedIn, kind of a look at where our graduates are employed from the Masters of Public Health. And across Australia, there are a number of people that work for state health departments, but also for non-government organisations as well, ranging from policy officers, research assistants, through to kind of health and safety, environmental officers, public health advisors, and a number of people that move into the research space in terms of public health. And then we also have others that actually work in other fields in terms of communication as well, and end up working in media and communication. So there's a range of kind of career options that are available to you after doing a Masters of Public Health. And for me, that's the exciting part, because you get to work across so many different disciplines, where you intersect with so many different disciplines as well. That's the exciting part about public health. In terms of the clinical medicine and public health, absolutely. So we have a number of students that do an MD as well as an MPH at the same time, and many students that will actually work into that space in terms of a clinical career and become a public health physician. Others on the panel might have more to add from to that as well. Maybe Linda, you have some more there.
Yeah, until early May, I was president of the Australasian Faculty of Public Health Medicine. So there is, as I mentioned earlier, a discipline within, or a specialty within medicine called public health medicine that specifically deals with communicable diseases issues, but not just communicable disease issues, a range of other public health challenges depending on public health physicians' area of expertise. And to become a public health physician, you need to have an MPH to start your training, and then it's a 3-year training where you're based as a public health registrar. You're required to move around and gain expertise and experience in different areas of public health. And then you have to submit a certain number of reports and pass an exam before you become a fully fledged public health physician. So there are some good opportunities in public health medicine. We're a small specialty. There's not a large number of us, but again, as I mentioned earlier, public health physicians have been really important, as have other public health practitioners in response to COVID-19, and there are a number of interesting job opportunities if you're in medicine and interested in public health.
Great, thank you, Linda. So the next question is about the differences that we see between the different countries, the responses that different countries have mounted. And a second part of that is about the confusion that people are experiencing. I'd just hand over to Lisa to perhaps cover off on some of the sort of an epidemiological perspective of that.
I suppose the first thing to realise is that you have to be very careful when you're looking at these graphs that have been everywhere recently that put all countries on one graph. Because one thing we do know is that there are many different ways of actually counting how many cases of COVID you have. But in addition to that, every country has a different testing regime. So what we do know is that the more you actually go out and try and find COVID, the more active your contact tracing is, the more testing you do, the more cases you will find. So that means that it's really misleading to put a lot of countries on the same graph without actually knowing the contextual information. The unknown thing about this whole COVID response is it is so new, right? So when we're trying to evaluate what interventions we should use, from social distancing through to enhanced cleaning, through to border closures, as Linda said previously, we're operating off our knowledge of other diseases, but COVID-19 seems to be a different challenge again. So at the moment, what we're doing is we're pulling together experts with broad expertise across a range of disciplines, including epidemiologists and public health physicians and infectious disease modelers, and going, what do we know about how this disease spreads and what's the best way to actually control it? What we do know from different countries' responses is that if you act early, you have a better long-term result. I think that's probably all of the countries that have done better are ones that actually put in place a plan early. And for example, in Queensland, we had a public health committee formed by Jeanette Young in January, right? So it was recognised early that we needed a response. So you get your, much like the title of this session tonight, your diagnosis in place early, your contact tracing in place early, and also recommendations around what you actually do when you find people who are positive. Once you start to do that well, then the less opportunity you have for cases to actually spread more broadly. The other thing I think is really challenging with COVID, and Linda might want to comment briefly on this, is this whole concept of asymptomatic cases being out in the community and spreading. And that's been a real challenge for the public health response, and also for the public to kind of think about, well, how can you control it if we don't know who's actually got it? So we're learning all the time, but I think the combination of things that we have done has flattened our curve in Australia. And, you know, the main thing we were really worried about was our hospitals being overwhelmed and people not being able to be treated. And we've managed to avert that crisis. And now we just have to be really careful reopening our society that we don't get another second wave of cases.
Thank you, Lisa. And I think the other thing to comment, I guess, is when we look at responses from a technical point of view, there's a particular response, and a lot of the differences we've seen have been, I guess, political responses, but also they also, I guess, the responses are in the context of the country, the culture of the country, and also the knowledge that people have of their own country. And so a group of advisors with the same training in the UK will provide different advice to a group of advisors in Australia with the same training. So it's very difficult to, I guess, look at success in terms of a global response. I mean, that will come later.
Can I just add something? Yeah. It's not just the culture, but you know, Australia tends to be, even in our most densely populated urban areas, where the population density is actually quite low compared to many countries, for example, in Europe and certainly in, well, most countries in the world. And so what this means is that because we've got less dense population, we will have had less spread early on in the pandemic. So responding earlier was easier because of this reduced population density. I would also I noticed that somebody asked the question about the vaccine or herd immunity, and just to speed things up, I thought I'd just quickly respond to that, if that's okay, Simon. Yeah. So in countries, even in countries where there have been large numbers of cases and large numbers of deaths, for example, early on in Italy and now in a number of other countries, the actual proportion of the population who'd been infected and therefore potentially developed immunity is still quite low. So what that tells us is that we really, you know, to aim for a situation where 60 or 70% of the population has been exposed and acquired COVID-19, we would be likely to see a very large number of deaths and people getting very sick and requiring hospitalisation. So that's why all the measures are being taken to try and limit that through such things as social distancing.
Great. Thank you, Linda. So the next question is one for Shelley with regards to whether public health students have the opportunity to work with NGOs and government.
Yeah, absolutely. So we have a placements course that's part of the MPH, and you are able to go and work with providers, and that's 180 hours across a semester where you go and work with an organisation. And the types of organisations that we have on board range from government organisations, non-government organisations, and actually private entities as well. So across the whole range there, you're able to get experience. And we do our best to match kind of your career directions and interests with where we can put you in terms of the placement. And I guess a lot of the academics within the school also have very strong connections across that the government and non-government organisations as well.
Great, thanks, Shelley. Just this one's on the prediction front. Does anyone want to have a stab at predicting? This is a prediction of the second wave. The second wave in international travel.
Go for it, Linda.
Yeah, well, I think the
too,
best we can do in terms of predictions is to look at what some of the infectious disease modelling is showing. But what that does show is that when some of the measures that have been taken ease off, that there tends to be, at least according to the modelling, then a gradual increase in the number of cases. But that can take some time, particularly, as I said, in places where we've got less mixing anyway because of less population density, such as in Australia. So it's likely that would continue to happen until we reach a level of immunity in the community, either through vaccination or through insufficient people being exposed. But generally when that happens, diseases aren't wiped out. They tend to come back when there's sufficient low levels of infection in the community, simply because it doesn't all happen at the same time everywhere around the world. So you, or even within a country, so you can get pockets of transmission that maintain, that then concede the infection elsewhere.
Lisa, did you have any?
No, I was actually going to suggest Michael's might want to talk a little bit about the modelling side and this R0 number that we start to see in the press.
Yeah, so the R0 is an interesting concept. So that's the number of cases that one person will the number of diseases that one person will generate by passing it on to them. So that's the R0 number that you hear. I mean, yeah, and the statistical modelling has been used a lot to try and model different mitigation strategies and to try and predict what different scenarios would be based on different strategies. So that was all very informative at the start of the pandemic when people were choosing which actions to take.
Great, thank you, Michael. And the question of international travel, I mean, really, I don't know that anyone can predict what will happen. It will, it's perhaps we will see a semi-permanent change to the way we travel. So it'll be interesting. So there's only a couple left. There's one on mental health implications, and I'm just wondering from the panel whether we have covered this sufficiently with Shelley's answer, or whether anyone wishes to add to this.
I think there's a couple of things we can add, Simon. I think the fact that the Australian government has actually already put a lot of funding towards mental health since the pandemic started. I think there's an awareness, absolutely an awareness, because of all the economic consequences and the change to the way that we're living, that it is going to impact on people's well-being across, I guess, in terms of not being able to find employment, but also just changes in living situations. And there's definitely been a lot of work done in terms of children who have been away from school for the last 5-6 weeks, where a lot of schools have been doing work in terms of being able to support children and their parents in that process.
Great, thank you, Shelley. So we're coming to the end of our session. We have one more question, which is a nice one to finish off, although I'm not sure quite how we're going to answer it, but it's really one around how, given the reactions at the beginning, what have we learned, and perhaps what can we do differently. I'll open this up to anyone who wishes to have a punt.
I'm happy to start. I think that the question about how we balance an early response with the avoiding panic, I think that's really about good risk communication. And I think we tend to sometimes, particularly with more environmental threats, there's has been a bit of a tradition, if you like, for trying to avoid panic by not necessarily communicating the whole risk. Because I think that there's pretty good evidence that when the whole risk is communicated, as well as strategies that people can do to avoid or limit the risk, that actually limits the amount of panic. And I think one thing that has been done really well in relation to COVID-19 has been that risk communication and communicating to people about the level of risk and what can actually be done to limit it. In terms of some of those bigger lessons, I think they will come out in the wash when there's no doubt that there will be evaluations of the response happening throughout Australia, and both at a Commonwealth level and individual jurisdiction. I mean, one of our challenges was having insufficient testing capacity early on when we should have been testing a lot more. That I'm sure there will be lessons that come out from that could be applied to future pandemics.
I'd just like to back up what Linda said. I think one of those key things in the risk communication is actually what actions you can take yourself. Because so often people think, oh, that's the role of experts or the role of government to do things. And one of the big lessons is potentially focusing on these simple infection prevention measures, how to wash your hands and the importance of social distancing and cleaning of surfaces. And these don't just stop COVID, they stop everyday spread of organisms. And those of us who work in the field know that, but we haven't got back to basics for a long time in terms of teaching our kids in school how to wash their hands. And hopefully some of these basic measures and even reminders for adults. I mean, I find it amazing that we had to remind people that it's, you can't just put your hands under the water for 5 seconds. You've got to actually use soap and spend 20 seconds to do that. That these basic messages around hygiene, hopefully people will then take a little bit of personal responsibility, because along with what Shelley was saying earlier around this war messaging, and it becomes all a bit too much. We know with that rhetoric that people switch off and they think it's someone else's problem and that they can't do anything themselves. And I do think that one thing the government has done well in the last few months is saying, yes, we're handling this from an expertise perspective, but you can do something as Australians. You can stay home. You can look after our essential workers. If you're working in, if you can't stay home, don't go to work if you're sick. Wash your hands. These simple things, I think we just have to keep re-emphasising.
Thank you, Lisa. And one thing's quite true is that humans as a species are very good at learning. So when you consider the future, it's certainly the people who have lived through the pandemic will be much better able to respond to a similar type of event in the future. And to some extent, that's why you saw very different responses in countries that had experienced SARS in the past, because the actual system itself had memory from that, and it was built into the structure of how they responded. So that is one of the, I guess, the good things to come from this is a greater preparedness, and I suppose it's a greater resilience of our systems. The challenge will be responding to the next one will be an unknown situation all over again. But I think we've exhausted our questions now and exhausted our panel. I'd like to firstly thank all of the attendees, the 54 of you who have tuned in and signed up for an hour and a half of thrilling discussion on pandemics. Sadly, for some of us, this is a very exciting part of life, and we enjoy it, and we enjoy sharing our knowledge with you. I'd like to thank all of our panelists, the program directors from the Masters of Public Health, Epidemiology, Biostatistics and Environmental Health Sciences. And most of all, I'd like to thank Associate Professor Linda Selvey, who is our resident public health legend at the moment, and she gave a wonderful presentation to you. But thank you, everyone. Thank you very much for giving us your attention, and we really hope to see you in the future. Thank you.